Victoria from World Health Organization, and it's a pleasure to me to share this session on the WHO Track Digital Learning Series, Technical Resource for Advanced HIV Disease Capacity and Knowledge. The session topic today will be about palliative care and advanced HIV disease. Next slide, please. Before we start the session, I would like to bring some housekeeping information that might facilitate the management of this tool. The interpretation will be available in French, Portuguese, and Russian, and is available by clicking the interpretation button at the bottom of the screen. Click on interpretation and choose the language that you like to hear. To hear the interpreted language only, you can click in mute original audio. Regarding chat and Q&A, please chat echo IT to troubleshoot Zoom problems. Also have the Q&A button at the bottom, and you can please use the Q&A feature for questions regarding the topic and presentations. You also have live transcription. Please click on show captions and caption will appear on the screen. To close the caption click, you can click hide caption. Recordings and certificates are available. This session will be recorded and your attendance is consent to be recorded. And a certificate of attendance and continuing education will be available through the University of New Mexico. It will be available via the follow-up email at the end of the session. Important to say that this link is only open for 48 hours after this meeting. Project ECHO collects registration, participation, questions, answers, chat comments, and pull response from some ECHO programs. Your personally identifiable data will be shared with the project funder. This data may be used for reports, maps, communication, surveys, quality assurance, evaluation, research, and to inform new initiatives. This is the layout of the agenda for today. We start with an overview of the palliative care and advanced HIV disease, followed by clinical case presentations, and also a panel discussion with the Q&A. At the end, you have a post survey and closing remarks. I will introduce each of the speakers before each presentation. Then it's my pleasure to start. It's my pleasure to start introduce the first speaker. The first speaker is Dr. Stephen Connor. Stephen is a PhD and is executive as a director of the Worldwide Hospice Palliative Care Alliance. He has worked in the hospice and palliative care movement since 1975, including 10 years as a vice president of the National Hospice and Palliative Care Organization. He is a researcher, advocate, educator, licensed as a clinical health psychologist with 20 years of clinical experience. Dr. Connor has over 175 peer-reviewed publications and is the author or editor of 6 books of palliative care. Stephen, the floor is yours.
Thanks very much, Marco. I'm having a little bit of technical difficulty here pulling up the slides. It's not giving me an option to bring my slides up. So we may have to go ahead and go with the ones that you have in the slide deck.
Can IT people, okay, great, thank you.
There we go. Great, all right. Well, thank you, everybody. Good morning, good afternoon, good evening, wherever you are. As was mentioned, I'm Stephen Connor, the Executive Director for the Worldwide Hospice Palliative Care Alliance, which is an alliance of 475 palliative care organizations in 103 countries. And we're going to be talking about palliative care and advanced advanced HIV disease. First, to just note, I don't have any conflicts of interest aside from an interest in getting care to people who need it. Palliative care is often misunderstood, and why, in terms of why it's important for people living with HIV. And I've been working in palliative care since the 1970s, including in San Francisco during the beginning of the HIV epidemic. But we all want a cure for HIV. Sometimes people think going into palliative care means that you're going to have shorter survival, but we often find people actually their survival improves when they're in HIV. Not everyone, of course, but many patients. Next slide. So what is advanced HIV disease? WHO defines advanced HIV disease as having a CD4 count less than 200, or stage 3 or 4 HIV in adults and adolescents, and of course all children 5 years or younger that have HIV are considered to have advanced HIV disease. Both people who are new to antiretroviral therapy and those who are returning to care after interruption in treatment, which can at times sometimes cause resistance to antiretroviral therapy. Next slide. So we actually have a problem with good mortality data for HIV. We know how many people generally have dying from HIV, but not what some of the secondary causes are. Fortunately, in 2019, we saw almost 675,000 deaths. That's now dropped as of 2022 to 630,000 deaths. But importantly, the regional differences in terms of mortality from HIV, almost two-thirds of all mortality in the African region, which is a cause for great concern. Of course, every region has some share, but really the lion's share, if you will, is in the African region. Next slide. So in general, I think, there's a shift from the idea of you have HIV or you have a acquired immune deficiency syndrome. And now we're seeing a sort of a shift in that people with HIV are at risk for non-communicable disease as well as communicable disease. Still, the majority of people who have advanced HIV disease will die prematurely because of a co-infection with TB or cryptococcal meningitis or a variety of bacterial infections. But we're also beginning to see, we've always seen HIV-related cancers, but we're seeing other organ failure, liver failure, lung disease, CNS diseases, strokes, even cardiac illness, as well as death that's related to substance use disorders. So go ahead to the next slide. Importantly, we see about a third of all deaths from AIDS-related illness for people with co-infection with TB. Out of the 1.2 million cases per year, it's about a third of the mortality rate. Another 15% for cryptococcal meningitis. Don't have good data on bacterial infection, but there's over 6 million deaths annually from other infectious diseases. Next slide. So we're also seeing, in some of the data, an increase in these other conditions that are non-communicable for the most part. Next slide. And an important paper that just came out in Lancet HIV last year on the burden of non-communicable disease for people in sub-Saharan Africa, people living with HIV in sub-Saharan Africa. And there's a higher prevalence of NCDs, including risk factors, including hypertension, clinical depression, obesity, hypercholesterolemia, metabolic syndrome, and excessive alcohol consumption. These are risk factors for people causing premature mortality. Next slide. So we're here to talk today about palliative care, and our organization, Worldwide Hospice Palliative Care Alliance, is in official relations with WHO, and our main project is the production of this global atlas of palliative care, now in its second edition, but going to a third edition, we hope, next year. It basically is painting a picture of palliative care need globally. We also have relied on the research done through the Lancet Commission on Pain Relief and Palliative Care. This is a project called Alleviating the Access Abyss, which signals that essentially the vast majority of people who need palliative care are not actually able to access it. And in this research, there was we developed a methodology for measuring what we call serious health-related suffering, which is a hallmark of need for palliative care. Next slide. And WHO, of course, has a definition of palliative care, and that is that the focus of palliative care is in improving quality of life for patients and families, adults and children, facing problems with life-threatening illness by relieving suffering, by preventing and relieving suffering, not just relieving suffering, but preventing it, and by doing excellent or correct assessment and treatment of pain and other symptom problems. People often think that palliative care is about end-of-life care, but the majority of people by far are people who need palliative care prior to the end of life. And the innovation, if you will, that really all healthcare should be doing is patient-centered care by not just focusing on the physical aspects or dimensions of living, but also the psychological, social, and spiritual issues, so that you have a more holistic approach to the individual, and treating every person as a unique individual. Next slide. So we have over 1 million people who die a week on our planet. We have a need for palliative care that's now over 60 million. Over 20% of that need is for people living with HIV. It's a very large proportion. And again, well over 25 million people at the end of life needing palliative care out of that 60 million, mostly who live in low and middle income countries. Mostly older persons, but we see a significant need for palliative care for children, and particularly children who are living with HIV. And severe problems with access to essential palliative medicines. And we estimate over 18 million of those 26 million without access to strong opioids if they're having moderate to severe pain, so they die in pain. Next slide. These are some of the conditions for adults. We see malignant neoplasm, leukemia, or almost 30% of the need for palliative care, but HIV, again, over 20%. We see problems with dementia, problems with stroke, with cardiovascular disease, chronic obstructive pulmonary disease, liver failure, renal failure, injuries, also severe injuries we're talking about that people will be living with and then dying from. Various others conditions, including TB. Next slide. This is for children, a little bit different picture, with HIV actually being more prominent than for adults. Congenital malformations, prematurity and birth trauma, a lot of, for children, a lot of injury and poisoning and external causes, protein energy malnutrition, again, cancer only about 5%, but a whole variety of conditions, including a significant number of rare conditions. Next slide. So we are dealing with a lot of symptoms, and when you think about palliative care, you're thinking about pain, but it's really a cluster of a whole bunch of different symptoms that need to be managed in the population we're talking about. Pain certainly is significant, and we have depression and anxiety, a lot of psychological issues as well as physical issues, weakness, fatigue, breathlessness, nausea, vomiting, constipation, dry mouth, itching, wounds, various kinds. So it's a complicated picture for both non-decedents and for decedents. Some of the pain incidence is higher in the decedent population. Next slide. And again, as I said, palliative care needs begin long before the last year of life. So the majority of patients or around 55% at least, are non-decedents, meaning that they present with these serious health-related suffering issues long before. And that need is going to almost double by in the coming decades. Next slide. So palliative care is, we estimate that of those 60 or so million people who need palliative care, only around 7 million are receiving palliative care. It's around 12% or so. We're redoing those calculations now, but we also know that we measure levels of palliative care development in 6 different levels, from nothing and no one interested in developing palliative care to palliative care that's integrated into the healthcare system. And you'll see, as you can see from this map, areas like North America, Western Europe, Australia are well developed in terms of palliative care, but the least developed is the African region, where we're talking about today the need for palliative care, particularly for HIV, but for other non-communicable conditions is greatest. And next slide. So we have worked with WHO in developing a new public health model for palliative care development that begins with communities coming together to address the needs of people with serious illness and bereavement. But every country needs to have health policies in place to facilitate palliative care happening. Research is continuous, and it's an ongoing challenge to expand and improve on our body of knowledge. We also, the big issues are really access to the long list of essential medicines, many of which are controlled substances that are needed for palliative care, but a huge need for literally millions of people to be trained even in the basics, primary care providers to be trained in the basics of palliative care, and integration of palliative care into the health system so that people with palliative care needs can have those needs met. Next, I want to thank you very much for your kind attention, and we'll go on with the rest of the program, and happy to join you in the panel later. Thank you very much.
Thank you very much, Stephen, for your nice presentation. Really impressive. I really appreciate the numbers. Quite important to see how the impact of HIV as a disease condition for palliative care, particularly in children, I believe is very important. It's sometimes not very aware. People are very not unaware of this. I think very important. Really, thank you for your excellent explanation. The next speaker will be Dr. Elizabeth Namukaya. She's a lecturer in the Department of Medicine of Makerere University College of Health Sciences and a palliative care physician in Mulago National Referral Hospital in Kampala. And she has worked in palliative care for the last 15 years. Elizabeth, the floor is yours.
Thank you for that introduction, Marco. Good afternoon, everybody. As already introduced, I'm going to present the case to illustrate the importance of palliative care in advanced HIV disease. Next slide, please. So just before I start the case presentation, I just wanted to give you a background of the context in which this patient was seen. So Uganda is a success story in the fight against HIV. And in 2022, the prevalence of HIV was 5.1, which came down from 30% in the 1990s. There were 65% decline in AIDS-related deaths between 2010 and 2022. And a survey was done among about 1.3 million people living with HIV. And they found that 90% of them knew their HIV status. And of those who knew their HIV status, 94% were on ART and 94% were virally suppressed. So near the targets of 95, 95, 95. Also, among the HIV patients that were diagnosed that year, 99% were tested for HIV and 33% were found to be HIV positive. In spite of all this success, it's still ranked 5th among those with the highest HIV burden. And also there are some challenges still with adherence. And in one research, it was found that less than half of the people had the 85 adherence to ART medication that is recommended. And still about 1 in 5 people will present late the first time with HIV for care. Palliative care plays a very big role in the management of people with advanced HIV, and I hope this case will illustrate the importance of palliative care. Please, next slide, please. So in Uganda, there are different models of provision of palliative care. We have home-based care where patients are seen at home or in the community, in the comfort of their homes. Then we have hospital palliative care consultation teams, this which offer joint care with other primary teams, inpatient hospital units, and outpatient services. In Mulago Hospital, where the case came from, we offer service which is a consultation service, and the model is such that we categorize patients that those who don't have complex needs, that is level 1 and 2, can be seen by anyone who has been trained in palliative care. And as in Makerere, which is, and Mulago Hospital is the teaching hospital for Makerere University, palliative care is integrated in the curriculum of medical students and nursing students, as well as postgraduate students. So all these can provide level 1 and 2 care, and all those we have given in-service training. And then they refer patients who are who have more complex needs, that is level 3 and 4, to the palliative care specialist team. Next slide, please. So the patient I'm going to talk about, Moses, that's not his name. Was a 42-year-old male who was employed as a painter, was admitted to Mulago National Referral Hospital as a referral from a peripheral HIV clinic with history of cough for 6 months and difficulty in breathing for 2 months. He had been found HIV positive in 2020 and was started on tenofovir, lamivudine, and dolutegravir. And he was getting them from a peripheral HIV center, sometimes after 3 months and 6 months, based on how he was feeling. 6 months prior to this admission to Mulago National Hospital, he developed a cough, which was productive of yellow sputum, had no hemoptysis, had B symptoms. He didn't think much of it, and he wasn't going to his clinic very regularly, so he thought it was probably a normal cough. But 2 months prior to admission, he started feeling difficulty in breathing, and this worsened. And after a month, he decided to go back to his caregivers, and they found him to be very sick and hypoxic, and was referred to Mulago National Hospital. This difficulty in breathing was worse on slight exertion and was even present at rest. He also had chest pain, left-sided chest pain at rest, but no other features to suggest cardiac disease. And other systems were normal. Next slide, please. So his past medical history has already said he was already on ART, and he did not report any being treated for significant opportunistic infections during this period. He was a father of 2. He had separated with his wife, and the circumstances were not very clear. He was uncomfortable talking about the details. So when he was admitted to Mulago Hospital, he was investigated for the cough, and a sputum exam was done, and the gene expert on the sputum confirmed that he had pulmonary TB, but not rifampicin negative. He didn't have resistance to rifampicin treatment. He was also hypoxic. Oxygen saturation was 80 and below, and was started on oxygen therapy and anti-TB treatment. And at that point, the ward felt they could manage, provide the palliative care, and receive generalist palliative care. He continued on his treatment, but after 5 months of the anti-TB treatment, our team, the palliative care specialist team, was consulted, because they felt after all this time, the difficulty in breathing was still significant, not improved much, and also he had chest pain. And for psychosocial support, and given that he was almost completing his treatment, He wanted to have a plan of care after hospital to transition him to home-based care after being on the ward for 5 months. Next slide, please. So when he came to our unit, we normally assess using this African APCA Palliative Outcome Scale Assessment, which is a tool that was developed for palliative care in Africa. It is a tool which assesses, which screens for holistic needs in a patient, but also the caregivers, given that palliative care is both for the patient and the family. And it looks at all the domains of the patient's needs, that is physical, psychological, social, and spiritual. And you can see the first two questions are on symptoms. And when we asked about his pain, he reported pain, which he rated at 3 out of 5. This score is from 0 to 5. And on pain, 5 is the worst pain, and 3 is severe pain. He also, the other symptom that was distressing was difficulty in breathing, which is scored at 5 out of 5, that it was causing him overwhelming distress. He also reported that he was worried about his illness, and this was overwhelming. He had not been able to share his feelings much, and scored it at 1 with other people. And he still felt that life was worthwhile. He scored it at 4, which means that most of the time he felt life was worthwhile. He also in question on peace, which is really exploring spiritual aspect. He scored it at 2, meaning that it was rare. A few days in a week would he feel at peace. And regarding having had advice and information, he scored it at 3, and he said he was told that he needed he may need long-term oxygen, but he didn't know too much beyond that. And the last questions are for the family, but this patient didn't have a caregiver, so they were not scored. Next slide, please. So after that screening, we delved deeper to find out why he had this overwhelming worry and not lacking peace, and also the other, to get into detail into these 4 domains. And the physical problems already were pain and difficulty in breathing. He had fever, but had improved a lot on treatments, and weight gain had happened. But he had lost a lot of function because he had to be on oxygen full time. And in the social issues, he had no caregiver. He reported that he had been abandoned by his family. That's where he was born, and the wife had left him. His father had died, but he had other siblings, but from a different mother. His mother was from another country, another East African country. So although his father had left him property to live in, his family network, on the paternal side, drove him out of it, telling him to go back to his mother. And so he didn't have where to live. He had lost his job because of the illness. He reported lack of food, and although food is available in the hospital, sometimes he did not like the same food that is provided all the time and wanted to eat something different. Also, he did not have money, and this was so important for him because sometimes he needed to make phone calls to just get in touch with his children. He did not have social support, and also self-care was difficult given that he was oxygen dependent. And also he had this problem of having migrated to the hospital to live there because he could not go home because of lack of oxygen. He was, in the psychological issues, he was very worried about his children in particular. And also he had this self-stigma. It was, he did not want people to talk about his HIV status, and every time he wanted us to be kept a secret. If we got new health professionals to come and review, whenever you introduced and you were explaining, he didn't want to talk about it. And if he did, he was very angry. Even exploring much about HIV, he didn't want, except for those people he built a relationship with over time. And he was isolated because he refused his family to come and see him. He didn't tell them, kept on telling them that he's not around. And when we tried so much to engage them, he said that he doesn't want his children to see him in this condition. And he was a very angry person. He was angry that his family had abandoned him. And as a result, on the ward, sometimes felt that he was uncooperative because every time, if you ask questions about his illness, he was angry and he was missing his children. He was also angry at God, asking why God can't do something about his condition, given that he had many complications. Next slide, please. So when we examined him, by the time we came in, he was still sick, but generally his nutrition status was fair and had finger clubbing, and his saturation was 94.5 liters of oxygen, but off oxygen he would desaturate. And he had features of fibrosis and the chest on examination. And also when we did a cardiovascular exam, we felt he had features of pulmonary hypertension. Next slide, please. So this was his X-ray, and the other tests were normal. And the CD4 count, this was the original CD4 count that he had from his primary peripheral health center, was 250. Next slide, please. So as palliative care, we came in to manage his symptoms. We encourage that he is adherent to his anti-TB treatment. When we reviewed him, he had severe pain and breathlessness. So we started him on oral morphine because his pain was severe, but also morphine being important in treatment of dyspnea. We also gave him Bisacodil to prevent constipation, continued with oxygen therapy. And once we started the morphine and treated the pain, we realized that it was possible to start weaning off oxygen as difficulty in breathing started improving. And because of less dependence on oxygen, he was able to start pulmonary rehabilitation, which is a bit away from the ward, and also able to ambulate when off oxygen. We kept on taking a self-report about his ARV adherence and TB treatment adherence. Next slide, please. Our social worker was involved, and he helped in mobilizing funds for food support and basic needs that he needed, like things for sanitation, ability to be able to call using his phone. And we have a team of volunteers in our team who are social workers. They offered him psychological support, and he actually developed a strong relationship with some of them, and those are the people who could trust most. They also gave him practical care, like they would help him bring food when necessary, go for tests, and also pick his drugs, and also for washing his clothes. And they were present to him as a spiritual measure and treated him with dignity. And most of the time, he kept on thanking them for changing his life. With the ward, we planned to get him home oxygen, and we started mobilizing for support and funds. But the problem is that also he did not have a permanent home. And also in Uganda, if you were to use an oxygen cylinder, filling an oxygen cylinder that the amount of oxygen he needed would maybe need filling it twice or once a week, which costs about $12. And that was a bit expensive. And the other option was to get an oxygen concentrator, but the electricity is a problem because they are all they need electricity to power them. So we also liaised with HIV center because although he was getting his drugs, occasionally his friend would bring his drugs from the HIV center. We realized that it was very important to transfer him, even to get further tests, so that if we transfer him to the HIV center in Mulago Hospital. Next slide, please. He improved markedly on our treatment, and he would go 6 to 8 hours comfortably without oxygen, would go off oxygen, go for pulmonary rehabilitation exercise, and even walk out of the hospital and come back. And normally he would usually take the oxygen more at night. This helped him a lot. It improved his mood and outlook on life. and his pain was controlled. He completed anti-TB treatment. He started doing self-care, washing his clothes and self-hygiene. And he reported initially, yes, his friend was getting his ARVs. He said a friend, but eventually we transferred him and he started getting the RT from Mulago Hospital. And he continued getting oxygen. It was very difficult to take him home because he had no permanent home, and also the logistics about oxygen at home became difficult. So he stayed in the hospital as we checked on him for the next 8 months, and we were supporting him. Next slide, please. Unfortunately, after those 8 months, he one time deteriorated, and he was reported to be weak and developed difficulty in breathing, and with altered level of consciousness. And when we checked him, his oxygen saturation had gone down to 60%, and now he became completely oxygen dependent. And we kept on wondering what the problem is, if he was on ART, and if he was getting all his meds well. We repeated the CD4 count and found that it was 71 cells. And so we started on high dose cotrimoxazole, presumptively treating for pneumonia. We did the other tests for advanced HIV, like serum CRAG, TB LAM, to see if it was a TB infection. They were negative. To our surprise, this patient was getting his ART, but it was all kept in his bag. Found so many tablets of supplies for the months, and he wasn't taking them. I think mainly probably because of his stigma. I think he could not find time to swallow them when other people are not seeing him. So we had to get him counselors from the HIV clinic for adherence support. And now he became oxygen dependent full time and bed bound. And he got sicker with respiratory failure, and we realized that he was not going to recover. So we started managing him as end of life care. We reinstituted the morphine and benzodiazepine to keep him comfortable. And also, at the last minute, through the trusted social worker, he was able to give us a contact for one of his family members, as we discussed that life may be short and time may be short, and he agreed to give us a number. And in case anything happened, he asked us that we can call that number. And he died after that time, and we called that number actually, and the family came, and and they buried him, and that was the end of the story. Although they also said that they were willing to reconcile if he had accepted to be contacted. Next slide, please. Our lesson is that it is very important for adherence, just not to take the self-report, but to do pill count. Yes, the patient didn't want people to see his pills, but I think, through the trusted social worker, it could have been possible. And also, this patient was found because he wasn't improving after TB treatment. Eventually, he was diagnosed to have post-TB lung complications. And these come when someone has had, one of the risk factors is having TB for a long time untreated. So it is very important to have TB symptoms screened for every time you see patients to promptly treat promptly, so that you prevent this. Because in our setting, we are seeing more and more people with this post-TB lung disease. They are oxygen dependent. We've had people stay on the ward for 2 years because they will not afford home oxygen. When we send them home, they can't continue for more than 2 months because of the costs. And then for our health system, we are planning to have a system where we can have home oxygen, and if we could get concentrators which work on solar energy. Thank you very much. I'm going to stop there.
Thank you very much, Elizabeth, by your presentation. Your case is very emblematic. Again, see how important is TB in the current HIV, despite of all the advance you have in terms of access to treatment, availability of preventative regimens for TB. This is still important killer, and particularly in the HD context, I think is important. Always have in mind that more integration among the services is important, and I think your presentation also brings this holistic perspective. It's not just about the clinical issues, but societal and psychological things, and mainly spiritual things should be considered in the context of management of people in advanced HIV disease. I would like to go to the next presentation and introduce the next speaker. That is Dr. Emmanuel Luirica. He's Executive Director of the African Palliative Care Association, a Pan-African palliative care organization with programs in several African countries. He is a board member of the Worldwide Hospice Palliative Care Alliance. He has served in several technical committees at the Ministry of Health in Uganda, Uganda AIDS Commission, WHO, UNICEF, UNAIDS, and also as a vice chairperson of the Council of Institute of Hospice and Palliative Care in Africa. He is a co-investigator on ongoing studies in palliative care and has been an investigator and published on several HIV, cancer, and palliative care research projects, and serves on a DSMB at technical steering committees of research studies in Africa. He has been a co-author of several chapters in cancer and palliative care books. Emmanuel, the floor is yours.
Thank you very much, Marco. Thank you very much, everybody, for joining us on this session. I'll focus on providing palliative care for advanced HIV disease from the context of looking at a health system. I hope you can see my screen. Can you see my screen?
Yes, Emmanuel, please go ahead with your presentation.
Okay, thank you very much. I work with the African Palliative Care Association, and the African Palliative Care Association works towards four main objectives. One is creating awareness about palliative care at all levels, and then the second one is strengthening health systems by integration of palliative care, focusing on policy, focusing on access to essential medicines, palliative care education, and service delivery through small grants. And then the third objective is looking at research, palliative care research. Our work also entails sustainability for us and for the other members of our organization. We do all this working with governments through their ministries of health, institutions, academic and research, as well as civil society. In my presentation today, I'll focus on a few issues around advanced HIV disease and how we can respond appropriately at local and national level. Good enough that Stephen has shared a lot of the background data, and so and Dr. Elizabeth has also done that at patient level. Can you see my slides move?
They don't appear to be moving.
Can you see my slides move?
No, they're not.
I think you're going to have to reshare and share the PowerPoint slides instead of you're sharing the slides, right? Not the full screen presentation.
Okay, let me share again if that's okay. Okay, I think you can share from your side because my slides are not moving. Can I stop sharing and you share from your side?
Yes, we should be able to share from our side.
Yeah, so that we don't waste time. We go to the second slide. Okay. Can you put in slide show? Okay, thank you very much. Next slide, please. The realities, the main focus will be that the reality, we have HIV in national health systems, and as Stephen gave a picture within the low middle income countries, and especially Africa. There are common patient needs in advanced HIV, and therefore they need to integrate palliative care into HIV care and national health systems, and improving that care level by level. Next slide, please. Next slide, please. We've had the definition of palliative care, and I'll not overdwell on that. Important for us not to forget children, and Stephen gave us the ground for inclusion of children, and we, especially in the low and middle income countries where prevention of mother-to-child transmission was a bit slow, we have children still who need palliative care for advanced HIV. In the picture, you have a girl with molluscum contagiosum, which is exploiting the low immunity that this kid had. Next slide, please. There are principles of palliative care. Again, I'll not overdwell there. Relief of symptoms, pain, a major one, affirming life and dying as a normal process, integrating psychological and spiritual aspects in the care that we provide, supporting patients to live as actively and as possible until death, and also the family as well. Next slide, please. We need to remember that there is a team approach that should be used right from the patient to the level of the health system. And palliative care ensures that we enhance the quality of life, and it may also positively influence the course of the illness. And it's applicable throughout the life course. Next slide, please. Stephen has already given us the figures, but what I want us to focus on mainly is that the majority, we have majority of adults and who have this problem, the need for palliative care, but out of all that, we have HIV as a major contributor to the palliative care need, and that which I've put in bold. Let's move on to the next slide, and that's a major issue for us. And also when you look at the figures from 2022, Stephen shared that as well, that the deaths from HIV-related causes were 630,000, with our region, the Afro region, accounting for being one of the most affected, accounting for 1 in every 25 adults living with HIV. Next, please. We also know that HIV increases the risk for some cancers. We have Kaposi sarcoma, we have non-Hodgkin's lymphoma, and we have cervical cancer, again in our region where HPV vaccination has dragged. We know that there are other issues associated with degenerative diseases as well as aging, and therefore you have an interplay between HIV, cancer, aging, and other NCDs. And the problem has been that much as countries introduce antiretroviral drugs, they then forget to create parity between ARV provision and palliative care. In fact, some countries have taken HIV out of their palliative care out of HIV strategic plans, which is a mistake. Next slide, please. In 2020, again, according to the Global Atlas, it was estimated that globally over 28% of the need for palliative care was among people living with HIV, but that was sitting at 33% within the low and middle income countries. Next slide, please. The common causes, again, Stephen has shared those, and these help us to know where the health system should focus. They may be due to HIV itself, it may be due to opportunistic infections, to cancers, the effect of medications. Next slide, please. And then that brings all the issues around pain management. How do we set up the system for pain management, for wound care, issues around vomiting, diarrhea, nutrition, physical and nutritional rehabilitation, psychological and spiritual issues, and addressing stigma, as we've had from Dr. Liz's presentation. Next slide, please. Pain is a major issue, either caused by HIV itself, as it affects nerves and other organ systems, a symptom due to other illnesses or infections complicating HIV, and of course, as a side effect of HIV medications, as we realize with some of the HIV medications that were used. Next slide, please. Of course, as we talked about cancer, that it can complicate HIV, especially advanced HIV disease, and that affects body organs. It causes metastasis, but it can also be a side effect of the anti-cancer medications, especially as they interact with HIV medications. Next slide, please. Kaposi sarcoma is a major one, as I said. Next. Infections. In this picture, you see somebody who got bone infection and then pathologic fracture with underlying HIV. Next slide, please. Iatrogenic causes due to the effects of the medications that we give patients. We must be ready to manage those as well. And nevirapine was a major cause of that as well, especially in our patients. Next slide, please. Again, that's a picture of nevirapine causing severe pain because of a reaction. Next slide, please. I've talked about nerve involvement, which may be due to HIV, tumor infiltration, other HIV infections common in HIV like CMV and herpes, and then medications used in TB that also affect the nerves as well as anti-cancer medications. Next slide, please. Next slide, please. Next. So the pain in HIV goes to all systems, and if we don't integrate palliative care into the health systems, for and including HIV, we have late referrals for appropriate care, and then they go to inappropriate care settings, unnecessary suffering, and increased patient care costs as they go to people who are not qualified or equipped to manage the palliative care needs so raised. Next slide, please. The barriers to palliative care integration into HIV care include lack of access to pain relief due to either international or local barriers, knowledge gaps at all levels, at the patient level, health worker level, family level, and even within the gaps within the national policies, and therefore leading to shortage of the medicines that are necessary, as well as inadequate numbers of health workers with the palliative care knowledge and skill. Next slide. Others include lack of tools for health workers, failure to appreciate the comprehensive approach which goes beyond antiretroviral therapy, and then stringent regulations and cost of opioids for pain relief and other medicines. And I've also talked about lack of knowledge at the 3 levels or 4 levels: patient, family, health worker, and policymaker. Next slide, please. So what are the benefits? The benefits include they go beyond physical, spiritual, and psychological. You get better patient outcomes, however short they may live, as well as their efficiencies for the patient and the healthcare system, especially where the governments do not meet the entire cost of care for patients. Next slide. There's also palliative care introduces a better bed coordinated service, cost savings, improves service use and coverage, and the quality of care. and better patient outcomes, as I said before. Next, please. If you integrate palliative care into the HIV and ART clinics, you'll have better adherence, you'll have less lost follow-up, better social support, better quality of life, less depression, and fewer psychological issues, as our colleagues indicated in that paper. Next slide. Pain is a major issue in advanced HIV disease, and there's need to invest in medicines to access for people to access in national level. And Uganda has done a great job by making step 3 medicines available for free, but also ensuring that health workers have the skill to manage and control pain, and ensuring that the public knows that very effective pain control medicines are available. And therefore the issue of awareness at all the 4 levels that I talked about. Next, please. I'll briefly talk about the WHO step-ladder approach to pain, because this is very central in patients who have advanced HIV disease because of the various conditions we've talked about, and therefore making the medicines at every level available. Next slide, please. We need to minimize over verticalization of palliative care so that even patients at the lowest level can access it when they have HIV or advanced HIV, and then maximize on service points and staff available to provide palliative care and in general, but also pain management. In Uganda has again done a good job in enabling non-medical doctors to prescribe these medicines. But also bringing a comprehensive palliative care integration nearer to patients is another issue that needs to happen. Next, please. Next slide. This is the gist of my presentation today. And no, please go back to the slide. This is the gist of my presentation today. And we've seen that people, when antiretroviral medicines became available and options for prevention and management of opportunistic infections became available, government sort of diverted from keeping palliative care within the system. And this is something we should never have done, but instead integrate palliative care into the system by ensuring that there is a package. And the recommendation from the Lancet Commission, and then the package that was developed for inclusion into universal health coverage has the components of essential palliative care medicines that cover most of the symptoms that we've talked about, in addition to the antiretroviral medicines, prevention, management of opportunistic infections, and tumors. This package brings essential palliative care medicines that are affordable and government should be encouraged to do that. The African Palliative Care Association is working with governments to ensure that these medicines are available. At the moment, we are working with UNODC and the Belgian government in the DRC, and then working with the True Colors Trust. We are also supporting smaller programs in various countries to ensure that they have access to services, including medicines. In addition, there is a package of essential equipment, patient supportive devices and technologies, as well as supplies that should be available as part of the palliative care response in the advanced HIV disease environment. I've included a link down there. People can access that package. The third component is training people at the different levels and deploying them appropriately to provide palliative care, not only for other conditions, but also advanced HIV disease, so that whether patients will recover from their severe HIV stage or not, they have access to palliative care given the multidisciplinary and well-trained health work teams. The last component that is again recommended, that we've also included in the package, is the psychosocial intervention. That includes many aspects, including spiritual care, legal aid where it is available, as well as social support for the patient, for the family, and the community in general. These 4 aspects are very important if we are to ensure that patients with advanced HIV disease access palliative care, because if they don't have access to essential medicines, if they don't have access to the equipment that are required and supportive devices, if they don't have human resources and other psychosocial packages, then it becomes a major issue, including nutrition as part of that. Next slide, please. So in conclusion, HIV remains a major contributor to palliative care need, especially in low and middle income countries and Africa in particular. And symptoms in advanced HIV disease can be overwhelming to patients, to health workers, to the health systems, as well as to family members. Palliative care integration into all health systems must be implemented to ensure that nobody falls through without receiving the care they need, and focus should be taken away from just individual services, but also the governments to ensure that they avail the package as it is required. Next slide, please. Thank you very much. The African Palliative Care Association can be accessed through those contacts, and we are celebrating 20 years this year. Thank you very much.
Thank you very much, Manuel, for your very interesting presentation. Your insights on general health system and policy issues, I think, are very important component and a lot of issues to be done by all. Now, I would like to introduce our last speaker, Dr. Stephen Watiti. He's a doctor and has been working in Milne, Uganda as a leading HIV and AIDS service organization. He's an HIV activist and ardent advocate for improving and sustainable health for all. In 2006, he started his weekly column on HIV in New Vision, Ugandan leading daily newspaper. He has published 2 books on HIV and AIDS, 100 Commonly Asked Questions, and Conquering HIV and AIDS, My Personal Experience on Living with HIV. The Tear Fund UK has recognized him as a HIV champion, and he has won awards from Ugandan Parliament, ActionAid International, and International Christian Medical and Dental Association for his outstanding contribution towards the fight against HIV Uganda and beyond. His current advocacy works focus on HIV and aging. Stefan, the floor is yours.
Thank you very much, Brother Marco, for that introduction. Nice to be coming to you all and listening to Dr. Elizabeth and Dr. Emmanuel make presentation. Made me go through what I more or less went through almost 25 years back. I am a clinician, yes, although now I don't practice because of retirement. But in 1999, when I was still active as a doctor, I had advanced HIV disease. I am now 70 years old, turning 71 next month. But I can say I've lived 2 lives, one life without HIV and another life with HIV. At the height of the challenges I had in 1999, I had advanced HIV disease. My CD4 count was 160 cells per mil, and my viral load was over 600,000 copies. I was not on any treatment because ARVs were not available in that in my country at that time. And I had TB. I first had TB in 1988, and in between, in 1999, I had another bout of TB, and this time it was MDR TB. So most of those symptoms that Dr. Elizabeth was going through, I went through them. I also had Kaposi sarcoma, a cancer which is common. Some of the pictures shown. Mine was actually oral Kaposi sarcoma, and I think I even had pulmonary Kaposi sarcoma. I was coughing out blood. But at the height of it, I developed cryptococcal meningitis. So I had all the 3 of them, MDR TB, Kaposi sarcoma, and the cryptococcal meningitis. I had just survived severe bacterial infection, also which I suffered around 1993. Luckily, around that time, I was started on ARVs. Somebody put me on ARVs. With hindsight, actually, some of the pain that I suffered was caused by the ARVs because I remember suffering from a condition known as lactic acidosis. My body was so weak. I was vomiting all the time. I had severe abdominal cramps. And so I was fighting for palliative care. Like Dr. Emmanuel mentioned, I was lucky that I got these ladies, actually the younger ladies, they were nurses, palliative care nurses who came and visited me and talked to me about palliative care. Like mentioned, like Professor Stephen mentioned, I knew this was end of life care, so and even my relatives refused me to take it. But luckily, these nurses had good counseling skills. One of them offered to pray with me, which I accepted. She prayed with me, encouraged me, and gave me morphine, which I did not take for 2 days. But later on, because of the severe pain I was feeling because of cryptococcal meningitis, I took it. And when I took the medicine, I improved a bit. Actually, later on, I improved quite a lot. I started eating because I was starving, and then started swallowing the medicine. Anyway, long story short, I decided to change course because I had been practicing general medicine. I went and started working actually with Dr. Lirika in 2004 in Mildmay, and some of those pictures he was showing, I remember seeing them. And then at that time, I felt really the importance of using a lived experience to help others. It wasn't very easy for me, and even my colleagues found it difficult. Having had crypto, many of them didn't even doubted my mental status. But I did share my lived experience of living with HIV. And I attribute my being able to live up to now really to that episode of being put on palliative care. Eventually, I was weaned off morphine. I no longer use morphine. The only medicine I use now is ARVs, and along the way, I developed high blood pressure, so I use blood pressure lowering medicines. So the importance of community, of people live with lived experience, people who are not necessarily medical people. Now, for me, I fall in between, and sometimes some of my colleagues in the community have wondered whether I'm a real community person. Some even they thought after the fact that maybe I was paid money to say this. I have sometimes had to swallow medicine in their presence, show them that I am also a person living with HIV, and take the medicine. So the importance of demystifying palliative care. And Dr. Emmanuel has done a great job, and even Dr. Professor Stephen, the importance of starting to demystify this and making it as part of the continuum of care. You note with Dr. Elizabeth that the patient was sent to them late. I think if they had started early and maybe identified the palliative care needs of this patient, that man, I call him a young man because at 40, compared to me, he was young, would be still here. But when palliative care is introduced, especially as more or less as the end, as if it is the final lap, people may refuse it. It's also the importance of having trained cadres, different cadres, rather than referring them up. I was like I was referred down, if you want, if I may use that. But I got people who were trained and were able to deliver a service for me. The other thing is the importance of supporting people with lived experience, be able to use it. Many of them may need advocacy skills, even communication skills, because many people find it difficult to say things and they are not able to communicate well. And because of frustration, they may say, why, what they're being open and talking about this. The other thing that Emmanuel and I think Dr. Stephen also mentioned is the importance of having materials. For example, I know you mentioned I've written 2 books about HIV. I've been writing another one, and I draw a lot from the book, the Atlas of Palliative Care, and also calling people like Dr. Emmanuel, Dr. Elizabeth, to ask them, because information about palliative care may not be so much, but having materials packaged in languages that is understandable, so that palliative care should be looked at as part and parcel of universal health care, together with prevention, health promotion, curative services, rehabilitative services, and palliative care indeed, as and when it's needed. And for people like me who might be used, because many people think that people who use palliative care may not be able to live, but for me now, I can see, as I mentioned, I've lived a fairly good quality of life and aging well because of palliative care. I know I'll need it, and therefore I make sure that I participate in palliative care activities, I educate myself, and the communities around me, the importance of knowing this is part and parcel of care. Yesterday, I had an experience. I was called by a wife of a colleague, actually a doctor, because this friend of mine, I call him brother, is not well. Okay, doesn't have HIV, but has another condition which needs palliative care. And he had been advised for palliative care, but he didn't like it. And the wife also didn't like it. But when I went and shared my story the way I've shared, and offered to accompany him to go to hospice, he did agree. And this morning, 2 days later, he sent me a message saying that thank you so much, my brother, for making the journey with me to hospice yesterday. For the first time in a long time, I had a pain-free night, and even my family were able to rest. Now you can see that a lot of, even in countries like Uganda, where palliative care is fairly available, people may refuse to use it for various reasons, but mainly because of lack of knowledge. And Dr. Emmanuel again put it, this lack of knowledge can cause a lot of suffering, lack of knowledge by the client themselves, lack of knowledge by the community, and I dare say lack of knowledge by even medical practitioners. I've seen medical practitioners who discourage patients from taking palliative care even when it's available. So it's important that all of us do this and personalize it, because it can come to any of us. It can come to any of us, and we should be able to have it as and when it is necessary. So my experience and the fact that I lived, recovered from TB, recovered from cancer, recovered from crypto, and I'm able to live good quality life, I attribute it to the availability of palliative care itself, but also the palliative care nurses who came and helped me. Unless we demystify palliative care and start early, instead of waiting for end, then we call in the palliative care practitioners, it would be great if a person, when a patient is admitted, people living with HIV, now we are seeing a lot of people with the non-communicable diseases like cancer, diabetes, and cardiovascular diseases, especially as we age. It should be that palliative care practitioners should be part and parcel of the care teams who start early and be able to identify palliative care needs of a patient proactively and be able to talk to them early and so on, so that they're able to take it up. I thank you so much for the opportunity to be able to share, and I look forward to especially continue, especially using my lived experience to help others, but also to encourage others, especially those who are on the call who may be having challenges. It would be great if we were at the forefront of promoting palliative care, demystifying palliative care, and ensuring that it is part and parcel of universal health coverage. To advocate for resources, but also to create demand for the services, because many people who have access to the services may not use them, as I've mentioned, because of myths and misconceptions about palliative care. I thank you very much.
Thank you very, very much for your very thoughtful and important testimony, Watit. Really appreciated that. There are now some questions and answers to be discussed here. I will, several of them already been answered in the chat. I have selected a couple of them that I believe WHO can give a better answer. Then I will start, but of course, if people want to continue to send questions, and even among our colleagues here in the panel, I think you can continue to the end of the session. Then very quickly, I'll go to what is in the Q&A session here. I have one question that is for WHO, I think. What are some potential updates or revisions expected in the WHO guidelines for advanced HIV disease in 2024? And how might they impact clinical practice and policy? Well, by coincidence, we had yesterday a conversation about this topic. And for information, WHO is now planning to develop a specific update of several recommendations in treatment and care. And of course, HIV, advanced HIV disease is a very important topic. It's a special chapter in our management here in WHO, HIV, hepatitis and STI department. And there are 4 topics that we are looking for update in a meeting by end of this year. One is about the use of CD4 testing as a preferred approach for diagnosis of advanced HIV disease. Despite to be a tool that has been recommended, access to CD4 testing has been still very challenging in many regions. They are trying to promote a more strong advocacy for use of CD4 tests as the preferred approach. Another important topic that we're looking for is really the development of recommendations around the post-hospitalization discharge package of interventions that people should receive after they leave the hospital in order to really improve reduce the mortality post-hospitalization, also improve quality of life of these people. There are several topics that has been discussed. There are several research that you're looking for, trying to establish a pack of recommendations to address this topic. Another topic that you address in the next version of their AHD guidelines is about the routine histoplasmosis screening for people living with HIV. Histoplasmosis is a fungal infection that's becoming quite common, not only in Americas, but in other regions. That's why I'd like to really improve the routine management and diagnostic identification of histoplasmosis in population living with HIV. And finally, another important topic is about the identification and screening and treatment regimens for Kaposi sarcoma. As we present in a couple of presentations in this session here, KS has become really a very important topic, and the palliative care around this topic is becoming very, very important to be addressed in our guidelines. There is also another question related to WHO that I'd like to answer, is how does the WHO tailor its response to advanced HIV disease in high-burden countries, particularly within the WHO Afro region, and what specific challenge does this region face in management of advanced HIV disease? I'd like to list some issues that were discussed recently. In terms of the main challenge that you face in the region, I believe that one is the insufficiency for testing. I think is really a point that we try to address in our next guidelines updates. The second is access to screening interventions, as I commented before, like histoplasmosis, even KS. But definitely lack of access to blood cultures and diagnostics to identify severe bacterial infections is another issue that's been very challenging in the region. Also, there's not enough use of the LF-LAM in advanced HIV disease in not identify TB cases. And the frequent recycling in and out of care, that's been a problem. Of course, it's not in this region only, but it's been a big problem everywhere about this issue of re-engaging in care has been a big challenge. And you are also developing specific recommendations in the next guideline cycle to address it, not only on AHD, but in general, as becoming a very important topic in the overall management of HIV infection at global level. I don't know if there is any other issue, but there is an important maybe comment from our colleagues here. I don't know if someone wants to make a comment or push any aspect before you close the session. Stefan, Elizabeth, maybe start with Stefan.
Okay, the last Stephen may be my brother who can come first. The last shall be the first. I just quickly to mention the importance of what, looking at this, because like in the case of Elizabeth with Moses, I think they really did well, but of course is that we took the eyes of the what of the main thing, HIV, and I know that the most important thing was adherence, the importance of adherence. So, but these are again learning points, the importance of supporting people who are faced with this severe disease, to swallow medication, even when you know it may not be curing you. That is the challenge. So that is something that I wanted to underline, the importance of adherence. Even on medicine for palliative care, they work only when they are taken according to the prescription. Thank you.
Any comment?
Oh, just thank you, Dr. Watiti, so much. I think hearing people with lived experience is really important. And I think there's stigma involved with HIV and also with palliative care that we need to overcome. And I think it's easy to think that, well, now we have antiretrovirals, there's no more need for palliative care. Why are we talking about it? And I think, as I hope we've shared with you today, there are real needs that people have, and regardless of whether they, as Dr. Watiti pointed out, I mean, he benefited from palliative care for a considerable period of time, but then now he's on with his life, and it's just it's an amazing story. Always, every time I hear it, I just go, wow, from him. And not everyone is as fortunate as Stephen, Dr. Stephen. He's an extraordinary human being, but we're all extraordinary human beings, and we just we all want quality of life and help when we need it, because the mortality rate remains 100%, whether it's HIV or something else. So those are my final thoughts. Elizabeth or Dr. Watiti, anything to add?
Thank you, Stephen. Thank you so much.
Sorry.
I think you're muted, Dr. Marco.
Sorry, my mistake. I don't know if other speakers want to give, almost at the end of the time for that, if any of the speakers want to give any final words or some comment, I appreciate that. Elizabeth or Emmanuel.
Yeah, I just want to emphasize the importance of integration of palliative care into the daily care of everyone who needs palliative care, even for HIV, advanced HIV, that it's important that everyone gets training, and even in daily work, even if you're not a palliative care specialist, you use a holistic approach, manage the symptoms you can manage, and refer to specialist palliative care services if those symptoms are complex and need a specialist. Thank you.
Yeah, thank you. Thank you very much, everybody. Thank you, colleagues. My comment is really to highlight the fact that without involving governments and ensuring that they allocate resources to palliative care in general, and in particular to include the package that we talk about, the essential medicines, the equipment, the personnel, addressing the psychosocial, spiritual issues, it becomes difficult because by the time patients need palliative care, whether due to advanced HIV disease, cancer, or other conditions, they cannot afford to use their own money to care for themselves. And therefore, the importance of us ensuring that palliative care is included at policy level, in strategic plans, and that governments allocate resources to palliative care. And as the African Palliative Care Association, we work to ensure that we pursue that so that we can get money from the money that comes from the taxman to be invested in access to palliative care. Thank you very much.
Okay, then
I realize how much of a challenge it is to build palliative care in resource limited settings, and there is, as we've talked about, bringing the community together as a compassionate community to help support people who have serious illness is half the battle. We also have resources on our website, whpca.org, for building palliative care in resource limited settings, and those are all free, and so please join us.
Okay. Many thanks to all presenters and people that have attended session. I think was very rich, very interesting, and very important, because the topic on AHD is really becoming a global problem that we are all trying to find better solutions. And the main objective is, of course, to improve the quality of life of people living with HIV, recognizing all this challenge that was presented here today in different dimensions, not only clinical, but also from the psychosocial, spiritual, and also from health system perspective. I believe it's important to address that. Before I close this meeting, I'd like just to remind people about the CME feedback survey. Please follow the link shared in the chat box to complete a feedback survey. The completion of the survey will allow you to receive continuing medical education credits and also the certificate. The survey links, session materials, and information regarding the upcoming sessions will be sent in a follow-up email if you have opted in to receive emails from the Project ECHO. They are also a vehicle pool that we also like to share with you, a pool regarding your interest in participating in smaller virtual communities of practice in the future that will provide a platform for future engagement and with colleagues and examine AHD topics through the discussions and dialogue and peer sharing. Please take a few minutes to complete that pool if you are interested in participating. Thank you all for the attention and have all a great day.